everyone. Today we will be discussing Chapter 22, Care of Patients with Head and Spinal Cord Injuries. After listening to this lecture and reading your chapter thoroughly, you should be able to describe the types of injuries that result from head trauma, compare and contrast a subdural hematoma and an epidural hematoma, discuss possible signs and symptoms that can be seen with a traumatic brain injury, describe treatment measures for those who have had a traumatic brain injury, describe the implications involved in increased intracranial pressure, explain the complications involved in injuries of the spine and spinal cord, and analyze and review the symptoms of low back pain and what educational measures are important for the nurse to consider in the patient care plan. Traumatic brain injuries include several different types of injuries. The most common cause is from falls, and then the second most common cause is caused by MVAs. The physiology behind this, minor head injuries can cause concussions, which is a closed head injury in which there is a brief disruption in level of consciousness, amnesia regarding the occurrence, and a headache. Contusions is a brain tissue bruise. Blood accumulates from broken vessels and edema develops. This could lead to ICP. A coupe-contre-coupe injury is an acceleration-deceleration injury. So this occurs when the head is moving rapidly and then it hits a stationary object. The coupe portion of this injury includes when the contents of the brain hits the inside of the skull, and then it bounces back and it hits the bony area opposite the site of impact, causing that second injury, which is the contracoupe. Subdural hematomas are caused by small ruptured blood vessels that leak blood into the space under the dura mater. And this is often the result of a fall. Epidural hematomas involve rapid leakage of blood from the middle meningeal artery and rarely from other vessels, which quickly elevates increased intracranial pressure. This is an emergency situation. It is very rare, but it is still an emergent situation. So for older adults, we need to consider that their brains tend to move more when trauma occurs. The small vessels tear more easily and may occur, putting them at risk for slow developing subdural hematomas. So their symptoms are often slow in onset. We also must monitor the client for several months for signs of personality changes, decreased level of consciousness, increased irritability, and other signs of ICP. When we are caring for patients with TBIs, we need to know the type of blow that was received and how long the patient was unconscious. Then we will also observe them for bruising, swelling, lacerations, and bleeding. There can also be possible skull fractures. We would see ecchymosis around the eyes and around the ears. Ecchymosis around the ears is considered a battle sign. There may also be otorrhea, which is fluid from the ear, which needs to be tested to determine if CSF is present. So we would test this using a dextro stick. This determines if there's glucose present in the fluid, which is an indication of CSF present. And then rhinorrhea, which is fluid from the nose. If you see clear drainage from the nose, this should also be tested for CSF. These patients can experience tinnitus, which is ringing in the ears. They may show signs of facial paralysis, and then they may have disruption of their level of consciousness. And there are varying levels of consciousness. They go from 1 to 6, 1 being alert, 2 being confused, 3 being lethargic, 4 is obtunded, 5 is stuporous, and 6 is comatose. Acute intracerebral bleeds that cause a hematoma will present with signs of unconsciousness, hemiplegia on the contralateral side, which is the opposite side, and a dilated pupil on the ipsilateral side, which is the same side. Diagnosis for TBIs, we will use radiographs, CT scans, MRIs with contrast, PET scans, and then we will evoke potentials, which just measures how long it takes the nerves to respond, and also an EEG. Treatment for TBIs may include all of the conservative measures are implemented. We would try to avoid a rise in ICP. First off, you will always maintain a patent airway, make sure that it is secured, and then we will raise their head of the bed 20 to 30 degrees with the body in correct alignment. This is to decrease any additional ICP that we could put on these patients just by gravity alone. We will want to obtain IV access for diuretic medications if they are indicated. And then there may be surgical interventions as well. A subdural hematoma is removed surgically, either like via a burr hole or by craniotomy incision and evacuated by suction or surgical instruments. An epidural hematoma is a medical emergency requiring a craniotomy to prevent death from increased ICP. So preoperatively, for these patients, we will make sure that the operative site is shaved after the client is under anesthesia. The client should shampoo with a special shampoo before a scheduled surgery. So normally that's chlorhexidine that we advise that they wash with, and then it is not to be rinsed off. And then usually the whole head is not generally shaved for these patients. Post-operatively, these patients will go to the ICU. We need to maintain the position according to written orders from the surgeon without any exceptions. Positioning is important to prevent additional increases of ICP. So elevate the head of the bed 30 to 45 degrees. We need to keep the neck in midline and prevent excess hip flexion. Use nasal suctioning only if there is an order for it. We would watch for signs of leakage of CSF from the nose and ear and operative site. If it is observed, it needs to be reported to the surgeon immediately. We will provide these patients with a quiet, non-stimulating environment, which decreases sensory stressors, which may then cause a seizure if we don't provide them with a quiet environment. And then we would report any neurological status changes promptly to your charge nurse or to the surgeon. So etiology and patho of ICP includes any lesion or fluid accumulation that begins to take up space within the cranial cavity, and this causes an increase in the pressure within that cavity. It can be due to swelling of brain tissue from injury or surgery, leakage of blood from a ruptured cerebral vessel, excessive production of CSF, tumors, abscesses, or any other space-occupying lesion within the skull. Normal ICP ranges from 0 to 15 millimeters of mercury. And there is a concept map on page 507. It is map 22-1, which gives a really good representation of all the changes that occur when brain injuries are present. I do suggest that you review that map. Signs and symptoms of ICP. The earliest sign is lethargy and decreasing consciousness, accompanied by slow speech and a delay in response to verbal cues. And then we have the classic signs known as Cushing's triad. This is rising systolic blood pressure, widening pulse pressure, bradycardia with full bounding pulse, and a rapid or irregular respirations. Treatment for ICP, we will admit these individuals to an ICU unit where they are treated with supportive care to keep the pressure from rising further through interventions to decrease the cranial blood or CSF volume. Osmotic diuretics such as mannitol, glycerol, or urea are administered to remove fluid from the body tissues, which thereby reduces fluid in the brain. We will need to monitor these patients' electrolytes and their INOs very closely. So you may have a Foley catheter placed to monitor their output. We also need to monitor the input very carefully. Furosemide may also be administered to help decrease fluid volume. And then Decadron is often administered to decrease the inflammatory response and cerebral edema if it's caused by a brain tumor or an abscess. We need to keep these patients' head of bed elevated 20 to 30 degrees and keep their head midline with their body to promote venous drainage. If ICP is dangerously high, a surgeon can insert a catheter into the lateral ventricle so that CSF fluid can be drained in very small amounts. We need to monitor their CO2 levels because CO2 is a vasodilator. So this can increase blood volume within the cranial cavity, which increased volume can lead to increased ICP. So hyperventilation can often be used in short-term settings to combat increased ICP. CO2 levels of 25 to 30 will improve oxygenation to the brain, causing vasoconstriction. Complications for these patients include seizures, hydrocephalus, which is excessive accumulation of CSF that may result in motor deficits, cranial nerve deficits, or decreased cognitive abilities. They may also develop diabetes insipidus, which occurs as a result from brain injury or edema of the pituitary gland. The pituitary gland secretes pituitary hormones that regulate the kidneys, and then antidiuretic hormone is released in adequate amounts, resulting in polyuria, and some may complain of polydipsia as well. IV vasopressin and fluid replacement is the treatment of choice, and then we will closely monitor INOs and electrolyte balances. This slide shows many different signs and symptoms of increased intracranial pressure. It is here for you to review. It's kind of a fun little chart that helps us to remember the different signs and symptoms for ICP. Injuries of the spine and spinal cord. The etiology, spinal cord injuries are classified according to their anatomic location. So there are cervical spinal cord injuries, thoracic, lumbar, and sacral. Signs and symptoms include severe injury to the cord above the level of the fifth cervical vertebrae, and it is often fatal if emergency care is not immediate. Interruption to the thoracic spinal cord at L1 and L2 causes paraplegia. An injury to the spinal cord that does not involve complete severance of the cord may result in temporary paralysis, which may subside as the spinal cord recovers from the swelling and initial shock of the injury. Diagnosis is done through physical examination and testing of reflexes. We may also do a CT scan or an MRI to determine the extent of the damage. And then treatment includes 4 main objectives. We need to save these victims' life. We need to prevent further injury to the cord by careful handling of the client through log rolling techniques and maintaining head and neck in proper alignment. They will repair as much of the damage to the cord as possible. And we need to establish a routine of care that will improve and maintain the client's state of health and prevent complications so that rehabilitation is possible for these individuals. Psychological care will include grief and mourning counseling. These patients will work through the different levels of grief. Those include shock and denial, anger, bargaining, depression, and adjustment. Some complications that we may see include spinal shock, which is flaccid paralysis and loss of reflex activity and of sensation below the level of injury. And then neurogenic shock, which is loss of vasomotor tone caused by the injury. So they may experience bradycardia, hypotension, venous pooling with decreased cardiac output, and occasionally paralytic ileus. Muscle spasms are another common complication. So as the cord adjusts to the injury, the paralysis will become spastic, and there will be a strong involuntary contraction of skeletal muscles. This can be severe enough to throw a client off. This should not be mistaken as a return of voluntary function of the limbs, and education must be provided to the family and the client that this is common with those who have had a spinal cord injury. Attempts should be made not to stimulate the muscles by avoiding grasping the muscles themselves, and utilize the palms of the hands to support the joints above and below the affected muscles. An autonomic dysreflexia is hyperreflexia. This is an exaggerated reflex response that these individuals may show. It's potentially dangerous to the client because it can produce vasoconstriction of the arterioles with an immediate elevation of blood pressure. This elevation of blood pressure can elicit seizures and retinal hemorrhage or stroke. So many things can be precipitated through autonomic dysreflexia. We can use tight clothing around the waist. Catheter changes may distend the bladder. Insertion of rectal suppositories may cause this. Enemas may cause this, and then sudden changes in position may also cause this. If symptoms exist, an emergency situation exists. These patients need their blood pressure lowered by placing the client in a sitting position or elevating the head of the bed at a 45-degree angle. And then we need to remove the stimulus if we can figure out what that stimulus is, whether it's an impacted bowel over its distension of the bladder or pressure against the skin at any point on their body. These patients will display orthostatic hypotension, DVTs are possible, infection is possible, skin breakdown, and then renal complications are all possible as well. So nursing management for these patients include continuous assessment for signs of decreased oxygenation. We need to monitor for blood pressure instability, monitor these individuals for infection, skin breakdown, GI or nutritional problems, and urinary problems. We need to plan, implement, and evaluate constantly. We need to stabilize devices and care for them properly. So pin site assessment is crucial, and care with sterile technique is crucial. If these patients have pins placed, there may be weights for cervical traction that must be kept hanging freely. And then there also may be a halo device that these individuals wear, and they should have their skin assessment frequently with skin care provided. Log rolling must be done with extreme care to avoid twisting the vertebral column and further damage to the spinal cord. CNAs should not be delegated to move or reposition clients with a neurological injury or after surgery. They could assist the nurse in log rolling the client with proper and specific instructions only. Next, we'll be discussing back pain and ruptured intervertebral discs, often called slip discs. This can be caused by careless and incorrect methods of lifting. Signs and symptoms include lumbar herniated discs that may cause pain that radiates down the sciatic nerve into the buttock and below the knee. There may also be muscle weakness or paresthesia. They may have muscle tightening and spasms to the area of injury is often common. And diagnosis requires a thorough H&P, diagnostic radiographs, MRIs, or a CT scan. Treatment, we will start off with conservative measures first. These include ambulation if there is no sciatic pain. Bed rest for 2 to 3 days is helpful if sciatic pain is present. We will rotate ice packs and heat wraps. A TENS unit is also oftentimes helpful for some individuals. This is a unit that sends out electrical shocks that interrupt the pain response, the pain stimulus from the area of pain to the brain. Acupuncture may be helpful, and NSAIDs often help to decrease inflammation. If the conservative measures are not effective, obviously we will consider surgery. These clients need teaching. For guidelines, for a client with low back pain or spinal injury, we need to make sure that these individuals bend at the knees with their back straight, and then they crouch to lift an item off the floor. They need to carry items close to the center of their body. Often they will receive physical therapy, so back exercises need to be performed twice a day. They need to maintain an appropriate body weight to decrease the amount of pressure that is on their spinal column. They may often use a lumbar pillow or roll when sitting and when driving for long distances. They need to probably stop and walk around during long car trips frequently. And then we need to consider how safely we can teach these patients to perform tasks in their day-to-day lives. They should not ever lean over without bending at the knees. They need to reach, they should not reach to lift items or lift heavy items higher than the elbows. They should not stand or sit for long periods of time. They should not sleep with legs straight out without pillow cushioning. They should not bend at the waist to pick up any items, and they should avoid twisting to the side to lift objects as well. That concludes your PowerPoint for Chapter 22. So what have you learned? These are the questions that I would like for you to answer and submit in Moodle for me before 2:45 today for your end of class activity. Next class period, we will be online. We will have a couple Kahoots reviews, at least one, if not two. Your med terminology sheets will be due that day. I have changed the due date in the Moodle calendar, as well as your ATI worksheet will be due that day. Once we have completed the post-lecture quizzes, we will then take exam 6 over chapters 21 and 22, and then we will possibly start into our new chapter after the exam is finished for the day. Thank you all and have a great afternoon.